Hello, everyone, and welcome to today's discussion on the 2026 CMS Physician Fee Schedule and RVU changes. My name is Nicholas Rodriguez, and joining me today is Scott Everett.
Welcome, everybody. I'm looking forward to our discussion today.
Let's jump right in. So, a few months back, we did a legislative update where we talked about the One Big Beautiful Bill Act. Scott, can we refresh on that a bit?
Yeah, so the One Big Beautiful Bill Act had a couple of things that directly impacts physician practices. Namely, they built into place a one-time 2.5% increase to the Medicare physician fee schedule. And we're going to break that down a little bit more today in our discussion. But also the big questions that came from the One Big Beautiful Bill Act came from Medicaid eligibility changes for tax subsidies for some Affordable Care Act, which is still in the news today. If you're paying attention, Nick, that's a big topic of conversation in Congress right now. And then, of course, that there were changes to limits to loans, grants, postgraduate education, things like that. And the impact that we were going to see from that, obviously, with the is going to lead to, some more unfunded care that they wanted to look at with the changes in Medicaid eligibility, more frequent insurance coverage verification. People are going to be changing coverages based upon what they can find and afford. And of course, with the changes to the funding of education going forward, the provider shortages that we're seeing right now are, they're not going to end anytime soon. In fact, they may get a little bit worse before they even get better.
Yep. And Scott, I think that was a good little recap there. Appreciate that. So, what we really want to talk about today is the changes to RVUs and how that's really trending for 2026.
Yeah, so the new physician fee schedule came out from CMS for 2026, and there were some changes that went into play with that you'll want to know about, particularly from the standpoint of changes to RVUs. So some of the things that we noticed that came across is that increase of the 2.5% from the One Big Beautiful Bill Act is reflected in there, and you'll see it. But what's interesting is that this year they've moved to a dual conversion factor for RVUs. So the way it works is that if you're a qualifying participant for the advanced payment model, then you will receive $33.57 per total RVU for the services that you provide from Medicare. And if you're not a qualifying participant, you'll receive $33.40. So there's about a 17-cent differential per total RVU based upon whether or not you are participating in the advanced payment model with Medicare. Now, that conversion factor increase is a good thing. However, there are some changes to the way that RVUs are calculated that you're going to also really need to understand going in. First of all, there was an efficiency adjustment that moved RVUs for non-time-based services. So basically non-E&M codes, non-office visit-based codes, decreasing in right around 2.5% per code. Little differences here or there. And we'll break that down a little bit, but that efficiency adjustment really comes into play, and you'll have to understand that could really impact certain specialties more than others. In addition to that, Medicare changed the way that they are paying on site of service differentials. So practice expense RVUs for facility versus non-facility. And that's going to very much drive the overall total reimbursement that you could see from Medicare based on your specialty and based upon where you practice.
Yeah, certainly quite a few adjustments there that groups need to be aware of, Scott. But let's dig a bit more into the efficiency adjustment. What are we really seeing there, Scott?
So work RVUs is something that our clients always talk about as, something that's extremely critical. It's something that's built into budgets, something that's built into compensation plans. It's something that they're utilizing to benchmark for productivity. It's a really important thing. Now, these efficiency adjustments have been planned since 2021, and these are basically adjustments to work RVUs for non-E&M codes. So if you'll remember in 2021, there was a big
Mhm.
adjustment and increase in work RVUs for E&M codes. Well, what CMS determined was that A lot of these non-time-based codes, a lot of these procedure-based codes are things that providers have gotten more efficient with, that technology has made a little bit easier, that things have really come into play that they didn't feel that those work RVUs for those particular procedures were really, completely accurate any longer. So they made some adjustments to it. Now, the impact of the RVU changes came for about 7,500 codes of about the ones that have work RVUs. There's about 8,300 codes that have work RVUs, and about 7,500 codes were impacted by it. Now, there's no change to almost 1,100 codes, mostly the time-based codes, the E&M codes. Those were not impacted by these efficiency adjustments at all. There were some increases to a handful of codes, not very many, less than 50. A lot of them were, 4 or 5% increases to some behavioral health codes that were out there. I did see some really odd, large increases to a couple of ortho codes that are really rare, not done very often, but
Hmm.
for some reason they felt needs to make some fairly large adjustments to codes like lengthening or shortening of thigh bones or tibias. Yeah, th things like that, that, like I said, they're not done very frequently, but they made big changes to those. But there were decreases to about 7,400 codes that were out there, and those codes really span kind of every category other than, yeah, again, the E&M and time-based codes.
And Scott, I'm glad you mentioned the work RVU decreases because in most cases we're seeing about a 2 to 3% decrease. Can we break that down a bit further, Scott?
Yeah, like you said, Nick, of the codes that were impacted, 95% of them were just 2.5, 3% decreases. And when you look at that from a number standpoint, it's a tenth here, a hundredth there. You may, for some higher end procedures, see a reduction of, 1 to 2 work RVUs for each procedure that's being done. But from a number standpoint, it's not big, but it can add up over a
Hmm.
large volume of procedures that you're seeing. And again, it goes across every grouping that's out there. It goes across surgical codes, radiology codes, pathology codes, screenings. Really, that just comes into play, that 2.5, 3% decrease that you're seeing out there. There were some codes that went less than 2%. Most of those codes were radiology codes. There's others in other categories, but most of those were radiology. And then there were some that had much larger decreases. Ones, again, just a handful of codes. They were mostly vascular codes, a couple of urology codes, things like that. And those had some decreases that were more than 10% decrease in the RVUs. I didn't see
Wow.
them as really high volume codes, but they're common codes. They're ones that I'm sure your providers are doing. It just, they're probably not in the top 10 to 15 codes that are being done within your practice. So just understand that that's where those work RVU decreases are coming into play. And so when you look at something like this, if you do have compensation plans that are based on this, if you do have benchmarking that comes into play strictly for work RVUs, just understand there are some specialties that are going to be uh, changed more than others than you're going to see. You're mostly office visit based, primary care, even some of your, medical specialties, things like that are mostly E&M and office visit based. They're not going to change that much, but some of your procedural, surgical specialties, gastroenterology, things like that are heavy procedures, radiology, pathology, those are gonna see those decreases hit a little bit. So the next thing that you're going to look at and see is the differential in site of service. And what happened here is that CMS had noticed that there's been a large decrease in the number of private practices that are out there and a large increase in the number of hospital employed physicians that are working. And because those hospital employed physicians are working in hospital-based facilities that receive Medicare hospital payments for those services, they really wanted to look at it and see, are these practice expense components really relevant? And so For the most part, what the philosophy was is we're going to move the facility practice expense component of the total RVU to about half of what the practice expense component for non-facility based services are. So if you're in a freestanding clinic, you're going to get about double that practice expense RVU that you're seeing. So what you see then is there's a reduction that came in your hospital-based services and the number of total RVUs that are being performed. There's actually a slight increase for those that are done in freestanding facilities in the practice expense component. Now, again, when we look at this from a percentage standpoint, some of the things that you'll see are fairly large percentages that went up, sometimes as much as 30 to 60% reductions in the practice expense component of the RVU. That said, when you look at it from a numbers standpoint, again, it's a tenth here, a couple of tenths there, one here, two there, something like that. It's, again, not really large per procedure that you're seeing, but again, it could add up over time. Now, what this means for you in the sense that I know a lot of people don't utilize the total RVU or the practice expense RVU from the standpoint of benchmarking or the standpoint of productivity and maybe not even budgeting. It is how you're reimbursed and it is how you're paid. And so the way that you need to understand this is that certain specialties that may be more procedure based and operate out of hospital based facilities, offices, surgical centers, operating rooms, they may see a sometimes 7 to 10% cut in what they're going to be reimbursed from Medicare overall. Versus primary care office-based specialties, you're going to see an increase of maybe 2 to 4, 2 to 5% that as that comes into play. So it's something that you really need to understand that again, specialties are going to be impacted very, very differently by these changes that have come across.
Yeah, and certainly a lot of changes. So I'm glad we kind of, covered all of this today. Can we start summarizing, Scott? How is this really going to directly impact practices and groups?
Yeah, so we were happy when that 2.5% conversion factor got thrown into the One Big Beautiful Bill Act, and we're hoping that at some point, I know they're working to try to make something like that fairly permanent, or at least base it on the medical cost index that is done every year. So they're hoping those increases can be permanent. However, that increase this year may be offset depending upon your specialty and your locations that may be offset by RVU modifications. So you really want to kind of understand that. Look at the differential in, the advanced practice model, advanced payment model that's coming across, and whether you're a qualifying participant or not, and understand that dual conversion factor coming into play, and understand really what's facility versus non-facility, where are you working, where are you operating, and then look for changes. There are always changes that come across. I mean, they publish updates to these fee schedules, even though it's usually only a couple of codes here and there every quarter, sometimes mid-quarter, things like that. That there will be changes that come across. They're usually not uh, big changes, but you want to understand that because you never know when something like that could come across. But really, what you need to understand is for your practice, for your providers, how is it going to impact your budget? How is it going to impact your compensation plan? Do you need to make adjustments in planning or preparing for these changes that have come across? Because what I'm finding as I talk to more and more of our clients and things like that, these weren't necessarily publicized very well with the changes in RVUs. And so really trying to understand and model and put in place something like that. And so, here's a dashboard that we put together. And really, it's just looking at what was done prior to this year. What do we impact the change are going to be? We can look at it from an RVU standpoint. We can break out work changes, work RVU changes versus total RVU changes. We can look at what we expect our projected reimbursement to change by. And then again, you're going to want to look at it if you're a multi-specialty, look at it by specialty. You may even want to break it down and look at it by provider.
Scott, thanks for sharing that. And with us being a healthcare reporting and analytics company, I think it makes sense that we have at least one dashboard in our presentation today. So that being said, we do help organizations with reporting and analytics day in and day out. And if you are, struggling with these changes, there's a few different ways we can be of assistance. Number one, we have a product called PDS Contract Analyzer, which allows you to load in proposed fee schedules and compare them against your current utilization. So in some cases, we're loading in 2026 Medicare fee schedules and doing a side-by-side comparison for our clients, against their current utilization and even prior utilization to, understand, the changes in their reimbursement, even RVU comparisons. And Scott, if I'm not mistaken, I believe just for that dashboard we had shown above, you had done a side-by-side comparison of CMS tables, right? Just for preparing for that. So that's just
Yeah,
a
it was a fairly simple thing where I brought in the new fee schedule from the CMS website, compared it to 2025, did some VLOOKUPs and some calculations, and that's really where I, found all of the information that we presented today was through that side-by-side comparison that can be done.
Excellent. And I know you had mentioned to me earlier that you had used PDS Dash to actually build that dashboard. And for those of you who aren't familiar with PDS Dash, it's really a dashboard automation tool that allows you to pull in different data sources and automate the production of highly visual dashboards that can be, burst out at different levels. So you can be bursting things out, by provider, by location, by specialty, and so on and so forth. So I think that's really a great way to do your, comparisons in this case, like you showed at, a provider level or RVU comparisons at a provider or specialty level.
Yeah, and really, if it gets, really high level, you could just look at your top 50 or top 100 codes too and see just kind of the direction that you're trending in. You don't have to bring in all of your codes where it can get, kind of messy and difficult to do. If you just want to look at those top codes, that can just be helpful to give your practice at least a better understanding of what the changes are going to do from an impact standpoint.
Yeah, absolutely. Anything you could do to prepare yourselves for these changes, the better off you're going to be as an organization. And that brings us to one of our favorite quotes, forewarned, forearmed, to be prepared is half the victory.
Yeah, and really that's the point that we want to look at, is that the more you know ahead of time allows you to put some measures in place to mitigate any bad changes that are out there, help you take advantages of any positive changes that may be coming into place. Just knowing what's coming can really help you be best prepared to move your organization in the right direction and find success.
And with that, we're going to wrap up today's discussion. Wanted to thank everyone for, joining us today. Certainly, if anyone has any questions or wanted to learn any more about the tools we had mentioned, or just discuss anything healthcare reporting or analytics related, we'd certainly encourage you to reach out. A couple different ways to do that. We also have a tremendous library of different healthcare reporting analytics topics on our YouTube channel. We certainly encourage you to take advantage of. And with that, we're going to wrap up today's discussion. Thank you again for joining us. And Scott, appreciate all the great insights.
Thanks for joining us today, everybody.